I'm Dr. Ronald Berkman, and today's video will be concentrating on well woman care. This is an important area of the practice of obstetrics and gynecology, which clearly is gaining a lot of traction and a lot of interest, and certainly there's been a lot recently written about it, pointing out how important this is for our overall care of women. From the standpoints of the goals of the presentations, following the review of this video, as well as assigned reading material and attendance at the discussion session, participants should be able to describe the components of a well woman exam, the major differences in approach based on age, the application of major screening tools, testing, and vaccination, as well as diagnosis and management of uncomplicated medical problems such as hypertension, diabetes, and obesity. Today's video will concentrate on the items listed in yellow. Now, when you look at annual exams, and this is where a lot of the well women care is conducted, there's a lot of common misconceptions. Some view that the well woman exam is basically just a pap smear and a pelvic exam, and that certainly has gone back traditionally over the years. Many women also feel that if they don't need a PAP, they can skip the OBGYN visit altogether. This may or may not be the case depending on how well a primary care physician is providing care in the areas that do concentrate on obstetric and gynecologic issues. Also, the feeling by some women are that if I feel well and have no problems, I don't require regular medical visits. And this is unfortunate because there's a lot of disorders and problems that are relatively asymptomatic that can be detected at a well woman visit. And also the more problematic complications of a particular issue, such as hypertension, can be prevented with early care. It's also felt that OBGYNs are not trained to do annual well women exams. Well, obviously this particular video and the accompanying materials are one of the steps or one of the approaches to make an OBGYN, particularly one in training, to become more competent in doing such exams. But one of the issues as one looks at how expanded these exams are is that some practices feel that these comprehensive well women exams are really too time consuming, and there are techniques and approaches that obviously can make these more effective and more efficient. And the whole role of well women exams is to really move our care in the so-called pre-disease stage, or at the latest, shall we say, the latent disease stage. So if you use as an example cervical cancer, the pre-disease stage or primordial disease prevention area is to inhibit emergence of risk factors. So sex education, talking with particularly young individuals about multiple partners, use of condoms, things of this sort, all are trying to deal with the issue before actually disease even becomes an issue. Then you get to the levels of primary prevention, and this also requires health promotion and specific protection. And certainly a classic example of this is HPV vaccination, starting again with preteens, both male and female. Then the next step would be latent disease or secondary prevention, and this is relatively pre-symptomatic diagnosis and treatment of the disorder. And in the cervical cancer example, this would be doing PAP and HPV testing and treatment with, for example, a LEEP procedure. And finally, you get to symptomatic disease or tertiary care, and here the goal is limit the disability or provide rehabilitation. This is where patients clearly are symptomatic, and the approach would be, for example, a radical hysterectomy. So the purpose of well women visits is to keep us up in the first two categories as much as possible. Now, where do women get their care in this regard? And I think the Kaiser Family Foundation has done surveys since 2001, every 3 or 4 years, that really give us some general information about how women in the United States approach their care, since it's a nationally representative survey of women 18 to 64 and covers things like health status, relationships to regular providers, sites of care, and the frequency of routine preventive care. And I think it gives us insight as to where we actually stand, and certainly points out there's certainly a great need in this area of preventive care. First, you can see through their surveys that almost half of women report they have a health condition that needs ongoing monitoring, care, or medication. And you can see, obviously, as you get older, this becomes more of an issue. But overall, women, about 45%, feel that this is an issue. There are some differences by race in that white women slightly more likely to feel that they have such a condition. And interestingly enough, rural women tend to feel or report that they have a condition that requires ongoing monitoring, care, or medication. But there are barriers to care for women, and there are a variety of characteristics. So when you look at the share of women reporting that they delayed or went without care for about a year, under the category did not have a regular doctor or provider, overall that was about 12% of women, but particularly was higher among women who are either on Medicaid or uninsured, tended to be a little higher in the Latina race, and higher in younger women. Having difficulty finding a provider that would accept their insurance plan, clearly this was a problem with Medicaid compared to, say, private insurance, and not too much variation by race or ethnicity, but certainly younger women appeared to have more issues in this regard. Overall, most women receive care at doctors' offices, but clinics serve half of uninsured women. When you look at particularly uninsured women and you look at clinic-based care, you can see in the orange, that's 48% of their care is in those areas, compared to when you look at women with private insurance, only 20% end up in clinics. One of the other sort of misconceptions is that there's a huge use of emergency rooms by individuals. And certainly the use is in the 6 to 7% of care for Medicaid and uninsured women, but certainly it's a very minority of only 1% of women who have private insurance actually seek their care primarily in an emergency room as opposed to a doctor's office. About 80% of women have had a recent checkup or women visit in the last year or so, but the lower rates are seen among some groups. Actually, this is within the last 2 years. So if you look at women with private insurance, they seem to do better. Medicaid women actually not bad, but the uninsured, as one might anticipate, far less are getting care or routine care within the past 2 years. Poor women, that's less than 200% of the federal poverty level, can see that there's a fall off compared to women who are not at this poverty level. And women who clearly say their health status is very good tend to get checkups more often than women, for example, who have fair or poor health. Counseling on health behaviors appears to be highest for diet, exercise, and nutrition. And you can see that there's some variation across insurances, with certainly a fall off for women who are uninsured. Interesting enough, when you look at smoking and alcohol or drugs use, Medicaid patients tend to get a higher percentage of screening, but this is probably because they tend to go to clinics where much of their reimbursement is based on actually doing a lot of this type of care. But when you look at the percentages of women who are actually being screened for alcohol or drug use or smoking and so forth, it is not all that high, and one would hope that it could be higher. About half of women report receiving counseling on mental health issues, and again, some variation by groups. If you have fair or poor health, you tend to get higher counseling in this area. Again, somewhat higher counseling if you have Medicaid type insurance. Now, overall, counseling rates for diet, exercise, nutrition, smoking, alcohol, drug use, mental health issues certainly have increased. And this is looking at data from 2004 through 2017, and certainly during this 12-year period of time, all of these various areas or topic areas have shown some increases, but some more than others, and certainly mental health and alcohol drug use tend to lag behind some of the others. Now, utilization of screening tests, clearly if you're uninsured, that tends to be less, and that's again because this requires probably out-of-pocket expense. But overall, when you look at women who have private insurance or Medicaid, they do get Pap tests on a regular basis. They do get mammograms much more frequently. But again, it's not 100% in terms of utilization. And certainly the utilization of colon cancer screening, most likely colonoscopy, is far off for women who are age 50 or older, regardless of their health insurance status. Now, there's a lot of misconceptions. Most women think a Pap test screening should begin before the age of 21. And if you look across all these various age groups and you look for the dark bar, this is the percentage who feel it should be before 21. Almost every age group feels this is the case, except for individuals who are 18 to 25. It doesn't change too much by race or ethnicity, though white women and black women tend to have a greater feeling that the screening should become earlier. Almost half of women think that women without family history of breast cancer should begin mammography screening before age 40. And this is certainly despite all the recommendations from groups such as the U.S. Preventive Services Task Force, which recommends a different rate of screening. And clearly only a small number of women probably who have specific issues should begin their screening this early. So what are the tools that are available to assist healthcare providers to provide well women care? And there's been, as I mentioned, increasing emphasis in this area. The U.S. Preventive Services Task Force has their own listing of task force recommendations. They grade the recommendations. They have web-based tools for desktop browsers as well as applications for mobile devices, both iPads as well as phones. The Women's Preventive Service Initiative of ACOG just recently released a whole screening tool, which is a large pamphlet that again goes across ages and tells what testing and what type of material should be gathered or presented as part of a well woman exam. And certainly also grades the recommendations, but tends to use the USPSTF recommendations as well as other organizations. And the chart, as I mentioned, sort of summarizes all this. It has web-based tools for desktop browsers, but none for mobile devices at present. And also it provides links that expand on recommendations. And again, the websites listed below are included on the materials sent to you earlier. Here's a screenshot of one of the USPSTF slides, and this is again looking at how things would appear on an iPhone if you look at sort of the four areas down below, and you can see that it provides you with a certain amount of detail, allows you to sort of look at a recommendation, say for cervical cancer screening, click on it, and again you get the detail as to why it's so and what is the precise recommendation. They also will provide grading of recommendations. Recommendations that are A or B, listed in green on this slide here, are recommendations they feel should be offered or discussed at the time that you're providing the service. Those that are listed in the yellow here or C recommendations are ones that will be provided under select circumstances where there may be different risks. And those that are graded D or I should not be provided, and their use is discouraged. And so if you look into, let's say, their browser, and you go down and say, well, I want to examine a patient of a certain age, whether they're female or male, and they also have you select whether they're a tobacco user or sexually active. And for an example, we'll take here a woman who's age 45. She's female, obviously, not a tobacco user. She's sexually active. And when you click on that, the screen will come up listing, for example, here the A and B recommendations. And they certainly would recommend cervical cancer screening. And if you clicked over to the right and on details or related information, it goes to another screen that provides backup for it. Folic acid use for prevention of neural tube defects, again pointed out for women who want to achieve pregnancy, talking about HIV infection and screening for it, as well as blood pressure, so on and so forth. And then there's another large number of recommendations that are only selectively, or actually a small number that are only selectively recommended, and then a large number of ones that are not recommended. Here are a long list of Ds, as well as recommendations that are clearly uncertain and certainly not recommended for regularly discussing with patients at a Well Woman exam. The Well Women Care recommendations of ACOG, again, has a chart that's provided to you where, again, all of the age groups are sort of spread out. And where you see these blue dots, these basically are the A and B recommendations of the U.S. Preventive Services Task Force. And so basically it sort of combines this in sort of one chart. And as you go down, you see circles with sort of an opening, not colored in with the blue. Those would be the B or C recommendations from that task force. And you look in the left-hand column, you can see there are a large number of issues that potentially should be discussed, such as alcohol use, anxiety screening, certainly blood pressure screening, contraceptive counseling, depression screening, interpersonal violence screening, so on and so forth. So it's a long list. And when you look at infectious diseases, you talk about potentially gonorrhea and chlamydia screening, in certain cases hepatitis B screening, certainly HIV assessment and discussion of potentially screening. There's immunizations that you have to deal with. And then you get down to cancer screening, particularly in the younger age groups. You're talking about cervical cancer, older age groups, breast, and potentially other types of screens, such as colorectal and even occasionally lung cancer screening. And of course the question is raised, well, how do I get this done? This is a lot to cover. And what do you do about it? Well, it's important that something gets done, obviously, because OBGYNs often are the primary care physicians. So you can't say that this should be turned over to them. I'll do a limited amount of this because, based on recent data, about 38% of young low-income women in, let's say, one large urban hospital clinic consider their OBGYN as their primary care provider and was probably the individual they went to the vast majority of the time. In another study of women presenting to private practices, 9 of them in Colorado, those with, again, women with an average age of 40, about 20% considered that their OBGYNs were serving also as their primary care physicians. And this feeling or this perception seems to be greater for women who are pregnant, who are mothers of newborns, and particularly if they don't have a lot of chronic health conditions. So we do have to serve in a primary care capacity, and certainly we have to improve our capability of doing well women exams. Another data or additional data from that Kaiser Family Foundation survey in 2017. When you look at women who are 18 to 44, almost 50% of women consider that their well women visit is provided or has been provided by their obstetrician gynecologist. This does fall off a little bit when you look at women who are beyond the age of 45. So women, a significant proportion of them will view that you as an OBGYN are providing the required care for their well woman visit. So again, we have to figure out how we can do this more effectively and efficiently. And this is, I think, again, also important since there's a significant proportion of women who view their health status overall as fair or poor. It's about 18%. Across the board, but as you get into women, let's say 45 and above, we're now gaining percentages that are substantially higher, and certainly, as noted on the far right, women who are at the lower ends of the federal poverty level, about a third feel that their health status is fair or poor, meaning that certainly we need to try to address some of these issues and hopefully not let them go on to complications that require more extensive treatment and care. So what are the approaches we can use to make such care more efficient and effective? I think clearly team-based care is important. And that's, again, allowing all the various individuals who work in an office to utilize their skills to their highest possible levels. Obviously, if you're part of a team-based care system, you should have shared guiding principles. As I've already mentioned, non-physician providers certainly can play a key role, and they can do much of the patient education. It does not require many years of training. It will require some training, but certainly it is an area that they can carry out in a very competent fashion. And it's important also when you're using team-based care to recognize that the patient and or her family as well are part of the team, and you have to use a shared decision-making in order to set patient-generated goals and increase buy-in. If you just say, this is what you need to do, and the patient really hasn't bought into it, you're basically wasting your time. And also, I think the other ways of making things more efficient beyond team-based care is maximize some of the pre-visit information gathering. So you can certainly send out to a patient questionnaires that deal with their hospitalization, surgeries, allergies, medications, a system review, and all the sorts of information that's important. And also, along with this can be screening tools for use of tobacco, alcohol, drugs, as well as anxiety and depression. Along with this, one should utilize and maximize the use of electronic record keeping. I think most practices now have converted or are converting to this, and certainly with appropriate utilization, you can make your life a lot simpler, though at the start it doesn't seem so. But certainly listing problems, history, physical exam, allergy, medications in a format which can be updated but does not to be fully redone at each visit is important, so that once you have listed that a patient has had, let's say, a tonsillectomy or appendectomy, you don't have to go through the whole thing at the next visit and put it again in the chart. It's already there and it can be referred to. Further, with the use of patient portals, much of this information that the patient states or prepares in advance can be inserted into the record. You can verify it at the visit, but once you've done that, then that should be hopefully the last time you have to deal with that issue. The patient may have to verify prior to, say, a visit, let's say a year or two from now, any differences or new issues on that record, but from then forward it does not change. And in addition, with the electronic medical record, it can be set up so that there are prompts for age-related testing or follow-up, so that if you're not sure, you know, is this when I should start mammograms, or is this when I should do immunizations for pneumococcus, you can, in many medical records that are electronic, have prompts that sort of advise you once a certain age is reached that this is something that should be done. And as I mentioned, there are a lot of screening tools now that your assistants in the office, whether it be your aides or nurses and so forth, they can certainly administer to patients, and or these can be sent out in advance. The CAGE substance abuse screening tool is well recognized being effective, and again, it's only 4 questions, so it's not a huge burden even to the patient, and it can be adapted to drug use, Screening for anxiety and depression also similarly can be done in advance. This is a PHQ-4 system that certainly has been utilized and is felt to be effective. We're certainly familiar also with the Edinburgh one, and this also can be dealt with in advance. And then even counseling can be approached with a non-physician for much of it, in that certainly once it's identified that someone is a smoker, that can be discussed with them. There can be training by an RN to certainly talk about how to quit, determine whether the patient is willing to quit, assist in the quitting attempts, setting up time schedules, and potentially working with the physician to prescribe medications such as Chantix, and then arranging for follow-up and support. And these are all things or approaches that do not necessarily require the physician to be personally involved for all of it. And as shown in this particular chart, the behavioral counseling approach here listed for smoking cessation actually should only take 7 to 10 minutes. And it's 7 to 10 minutes that a physician doesn't necessarily have to be involved with. So in summary, I think when we look at well women care, it's an important role for healthcare providers in an effort to increase our efforts in the primary prevention of disease. Provision by OBGYNs will improve the overall continuity of care of women throughout their adolescent and adult lifespan, so that patients will stay within your practice if they feel you're meeting their needs. Clearly, adaptation of team-based care, maximizing the use of electronic medical records, particularly with patient portals, can make the care more efficient and effective. And looking at age-based algorithms, we will continue to see them evolve and be adapted for use on computers, and they will change as more data comes out as to when they should be utilized and how effective they are in certain situations. And as I said, can be adapted for use on office computers or even electronic devices such as phones and iPads. Again, as mentioned previously, an important guiding principle in order for well women care to be effective is that the patient and families are central to it and have to be actively engaged as members of the healthcare team in this process of care. So without their buy-in, obviously your effectiveness in getting much of what needs to be done and well women visits and to change behavior will not be as effective without that buy-in.